Okay. Happy New Year 2021. First of all, I wish everybody safe, healthy, and peaceful, year this year amid Corona, environment. This is the first web lecture for the international student, mainly Japan. And many Japanese student, resident, and young physicians participating, I think. And this is going to be also shared with the University of Hawaii medical student later. My co-host is Dr. Emi Saigusa, and she's going to introduce Jane to everybody. And then after that, Jane going to start the lecture.
Aloha, everyone. Thank you for joining us for our very first Junior Senior Special Lecture of the year. I'm Emmy Segusa Beecroft from the Office of Global Health and Department of Surgery at the University of Hawaii John A. Burns School of Medicine. And today we have participants from all over the world, from first year medical students to professors and program chairs in Japan and the US, possibly other countries as well. So please feel free to use the chat function throughout the lecture, and questions will be answered during the Q&A session. 日本語で質問いただいても通訳しますので大丈夫です。If you would like to stay anonymous, you can private message me for comments. And if you would kindly mute yourselves for the duration of the lecture, we'd appreciate it very much. And now I'd like to introduce Dr. Jane Yee, our honored guest lecturer of the day. Dr. Jane Yee is currently a global health fellow at the University of Utah. He also practices in Wyoming and the Navajo Nation. And Dr. Yee graduated from the State University of New York, SUNY Downstate College of Medicine. And she's also a graduate of the Albert Einstein Emergency Medicine Residency Program in Philadelphia. Thank you very much for agreeing to do a lecture. And I know you just came off a night shift, so we really appreciate your devotion to international medical education. So now here's Dr. Jane Yee, all yours.
Hi, everyone. Happy New Year. Thank you for joining, and thank you for having me. So I'm going to start sharing my screen here, if that's okay. And I'm really bad at paying attention to the chat while doing the presentation. So if anyone ever wants to stop me in the middle of it, please just flag me down. All right, I'm going to start my share screen then. Right here. There we go. So I'm just this is gonna be a very a broad lecture. If you want any more details, please feel free to ask me more questions at the end of the lecture, or you can email me after as well. Just as there's so much to cover, and I'm just gonna give you a glimpse into what American emergency medicine is like. A little bit about myself. So I'm born in New York. My parents were from China and they immigrated there in the 1980s. So I consider myself as Chinese American. English is actually my second language. I don't think I spoke English till maybe in the first or second grade because I actually started Chinese school first. But I am the oldest of two siblings. I am a first generation college student as well as a physician in my family as well. Right now I'm in Utah, and practicing as an ER doc, and you may wonder how I got from New York all the way to Utah and how long that journey took, at least for me. So here's a little, right here is a little bit information about the minimum requirements of how you get to be an emergency medicine doctor in the United States. Now, this is going to be slightly different from person to person. Some people may take longer, but this is the minimum requirements. So in the US, after completing high school, you typically end up doing a 4-year college degree. You do not go straight into medical school like a lot of countries do. So college here, you complete an undergraduate degree, and most people finish it in 4 years. Sometimes it's 3. It's whatever major you want, as long as you complete your pre-medical requirements for school. And there are very specific requirements, like you have to take biology, you have to take calculus, you have to take chemistry, chemistry lab, organic chemistry, and a bunch of other requirements to get into medical school. But technically you can study whatever you like. It could be English language, it could be public health, it could be engineering. As long as you do your requirements, you can apply to medical school. And applying to medical school also entails taking about a 7.5, like 7.5 hour, what we call the medical college admissions test, which has changed over the years since I've taken it, but it usually comprises of a biology aspect, chemistry aspect, physics aspect, and now there's like a social science aspect to it too. But this part, sometimes people do take time between because you can switch careers. So sometimes between college and medical school, we call it non-traditional students, where they may have worked in another field, perhaps in finance or anything else, and they've decided to have a career change. It doesn't stop you from applying to medical school. I, in fact, took a year off after graduating college and working in a research lab with stem cells research before feeling like I was ready to apply to medical school. And then there's a whole interview process, and finally you get into medical school. Here, traditionally, it's about 4 years. There are some programs here that may be a little bit longer. Perhaps if you wanted to do an MD PhD program, some medical schools will give you 5 years if you wanted to do an additional year of research. And the traditional modality of learning here is usually it's 2 years in the classroom, learning laboratory and clinical kind of information. And then the 3rd and 4th years is when you do your rotations in the hospital environment. There are some changes to some of these schools where you can start a little bit earlier, but that's what the traditional is. 1st year and 2nd year, you're kind of stuck in the classroom and doing anatomy lab and listening to lectures and not quite interacting with patients yet. Sometime between the 1st and 2nd year of medical school, you do take this very important medical licensing exam. We call it the step 1. And this previously, I would say, is considered the most important exam that you take in medical school, because a lot of residencies or specialties that you eventually go into kind of screen you by what what your test scores are. So the more competitive residencies like dermatology or orthopedics and neurosurgery, they usually go by this one test to kind of screen you whether you are eligible to apply the program, whether they want to interview you at all. Maybe there's an exception if you've done something else amazing in your life, such that this doesn't matter as much. Like if you were a Nobel Prize winner, then sure, maybe your step 1 score doesn't matter as much. But usually this is the most important test you do take in medical school here. This is going to change in the near future because they are going to change the step 1 test to a pass-fail test. So most likely that's going to change the emphasis of the numbers and scoring to the step 2 clinical knowledge test, which is a 9-hour test. The difference is that this one has a little bit more to do with clinical care, patient care, than step 1. Step 1, I would say it's more basic science knowledge, and maybe it's a little bit less applicable to your everyday practice. And then finally, we also have this second 8-hour exam that you can maybe take during your 3rd year of medical school, where you have to interact with people that pretend to be your patients. Obviously, this has been delayed, we'll say that, during the pandemic, and because we're not doing any in-person testing, and I don't really actually know the state of this yet. A lot of my friends haven't taken it yet. So those are the 3 tests you have to take in medical school before you apply to residency. Now, residency is interesting here because so you get all your extracurriculars together and your test scores together. You decide what kind of residency you want to apply to. And there is a whole matching process after you apply to all these programs, the ones that like you, interview you, and then you rank them as your favorite and then to your least favorite. Similarly, they do that to you. And on this magical day in March, a computer will spit out which program will match you to a program. You don't have 100% say to which program you get to go to. It's all done by an algorithm. So that's the weird and interesting part about how we do it here. But the residency matching process is interesting. But here's some of the data that we have here. Specifically here, we're in emergency medicine. You can see that every year, since this only shows from 2016 to 2020, but every year the number of emergency medicine residency slots increased. So in 2016, it was almost 1,900, and now we're at 2,600. Most of these slots, as you can see though, is filled by MD or what we call allopathic medical school seniors, 1,700 out of all of them. And from all of this, it looks like only 13 slots last year was unfilled. So most of the time, all of these positions get taken up. And then if we want to break it down a little bit more, this is for foreign trained physicians. So when I say foreign trained, I mean anywhere else in the world. Every year, it looks like there is more and more physicians that do successfully match for their PGY 1 year. I'd say it's around 60% in 2020. This is just the MD and DO match here, but if we want to break it down to a little bit more, so it's interesting here too, because we have allopathic medical physicians as well as osteopathic medical physicians here. Their training is very similar to us, qualifications are very similar to us. It's just historically they started in a different teaching / mentality to what medicine is, but right now it's all standardized, and DO and MD seniors are very comparable. But it looks like with here, you do have an increase in your foreign medical students applying to our programs here. Now, if you look at the breakdown, it is still this is the 2020 data. It is still very, very hard for a non-US international medical grad to match into the US for residency, especially for, I mean, you can see here that there's a better chance if you're doing a family medicine residency, but last year, emergency medicine only took in 30 applicants. It's not that it's impossible, but you'll have to do a lot more work to get into those positions. And I do know a lot of other physicians that come in, and part of it might be because a lot of other foreign countries also don't recognize emergency medicine as a separate specialty. So where I did residency in Philadelphia, we had a lot of Venezuelan medical graduates that came and matched to our institution. But in their country, emergency medicine is not a specialty. You know, in the emergency room, it is just their surgeons and their regular internal medicine doctors that practice down there. So maybe a part of this is also due to lack of awareness or lack of interest in actually applying to emergency medicine because you have no exposure to it as a separate specialty. But without any way of knowing, you can see it's a very small percentage of the entire number of positions being filled. But as a foreign medical grad, I would say, like most graduating seniors here, your number one chance to open more doors is to make sure your test grades are very well, because a lot of the programs here will screen you by a minimum cutoff grade for your step 1, step 2 scores. We do that here at the University of Utah. I'm not going to say what the numbers are, but there's usually a cutoff where they don't look at your application, because sometimes you get so many interested applicants that it's hard to start cutting down somewhere. And the second most important thing in terms of matching to emergency medicine, after a survey of program directors across the country, is actually what we call the standardized letter of evaluation. 97% of emergency medicine program directors here say that's after the scores, that's the #1 factor in their decision to offer an interview. And how do you get this SLO? This is the shorthand saying this letter of evaluation. The SLO is actually generated when you are rotating. Unfortunately, I mean, this is hard. This is going to be hard during a pandemic, but traditionally you would do an audition rotation at an emergency medicine program, and then they put a composite letter for you that writes about your strengths, your weaknesses, and how you could add to the program. So the other thing that would help improve your chances of success in matching to your emergency medicine residency here is to try and actually do an audition rotation here in the US so you can get this letter. It may be hard to find a rotation because there are places that don't take foreign rotators. But I think it's important to use the existing connections that you already have and looking at the patterns of where there is a high percentage of foreign medical grads that are accepted or have rotations. So traditionally places like in New York have a very high percentage of taking foreign medical grads for both auditioning and eventually matching. So, and you could find that data online as to which states and schools are more friendly to foreign medical grads in terms of sponsorship or even having them. And then usually for applying for emergency medicine residency here, you also have to go through the Educational Commission for Foreign Medical Graduates. It's also known as the ECFMG for short. They kind of just compile together if your medical school meets the minimum requirements of standards to even apply for a US residency spot. They make sure, unfortunately, you have to take step 1, 2, and 3 before applying, whereas traditionally here as a US medical grad, I don't take step 3 until I am in residency. So you'll have to have all 3 tests done beforehand. And then usually they'll also help you schedule your clinical skills test too. And there is also an aspect of proving your English proficiency. Right. So now we're coming back to this. So after that whole process of trying to match into residency, which is a very stressful situation, I'm sure Kumiko can tell you about it, but there's that one day in March, all of the medical students gather together and they open this envelope where it's like everyone tells you where that one spot you matched at, and maybe it's your dream slot program and maybe it's not. But once you do match, residency here for emergency medicine is anywhere from 3 to 4 years. Now it's kind of a newish specialty in terms of the world of medicine. That's why there is a difference in how long it is. Some programs started with 3 years, some programs started with 4 years. As to which one is better, there's really no consensus about it. But either way, you get supervised training underneath an attending, and you have minimum requirements that are actually set forth by our ACGME, our Accreditation Council for Graduate Medical Education, where they do have standards for all programs. So for example, it doesn't matter if you're a 3-year or 4-year program, everyone at minimum has 50% of their rotations has to be in the emergency room. At minimum, all the programs have to have at least 16 weeks of ICU training, dedicated ICU training. 20% of your education has to be in pediatrics. So they do set the standards of what your education has to be in terms of your rotations. They do set the standards of the kind of procedures and the number of procedures you have to be proficient in residency, such as you have to have a minimum of 25 baby deliveries or an X number of intubations and cricothyrotomies. So they do have standards that they set for every single program. So theoretically, whichever program you do match to, you should be graduating as a proficient and knowledgeable ER physician. There are certain perks to 3 versus 4-year programs. Some people do think that, hi, with the 4-year program, I have more exposure and more time to learn, and this is more comfortable for me, and I'd rather go that route. So that's why they'll choose a 4-year program over a 3. Sometimes 4-year programs will also give you more elective time because you have an extra year. So with that elective time, you can do extra research, different rotations to kind of help improve your medical knowledge, or even kind of improve your application for fellowships if that's something you desire. The other aspect of it is that's an extra year of residency you have to do without an attending salary. Attending salary here is probably at least 3 times is what a resident makes, 3 to 4 times what a resident makes. So some people don't see the utility of doing an extra year of residency. Also, especially if you're going to apply to a fellowship. I ended up doing a 4-year residency. I felt very comfortable with my knowledge graduating out of a 4-year program. But here's I'll show you a sample curriculum from one of the 3-year residencies. So this one's from the University of Rochester in New York. PGY1 just means your first year, second year, and then this is your 3rd year. But this is a sample of what a lot of the curriculum might look like. There are minimum requirements. You see here, at least half of it is going to be emergency medicine, and then everyone is required to do anesthesia as well as OB, ultrasound. So these are the minimum requirements. Trauma. And then here would be a 4-year curriculum. And this is from where I did med school in SUNY Downstate in New York. This is what their 4-year emergency medicine curriculum looks like. So at the end of the day, they end up having more time to do elective here. They have an admin shift here. And they probably also have more weeks of ED. Each block here is 4 weeks long. So just an example, but every program is slightly different. And here you notice that they have a lot more time to do electives. So whether that's going abroad to do global health rotations, whether that's people have very interesting things that they do with their time. Sometimes people like to do rural health rotations. So it's whatever you make of it, and it's what you think will help your career grow. So sometimes that's the benefit of having a 4-year program, is to have that extra time to learn things that you want. Okay, moving on. So then after finishing residency for the 3 or 4 years, you technically become an attending physician. Now, sometimes people put fellowship before attending physician, sometimes they put this afterwards, but either way, you're an attending after you've graduated out of residency. So while I'm doing fellowship here, I'm technically an attending in the ER. I supervise residents. When I'm at the university, when I'm at Wyoming, I practice alone. There's no one else there. It's just fellowship for us, at least in emergency medicine. It gives you extra protected time to develop an area of expertise. For me, it's global health, but there's many other options, whether that's medical education, ultrasound, critical care, toxicology, pediatric emergency medicine. Some of the other more niche fellowships that people do are addiction medicine, clinical informatics, hyperbaric medicine, sports medicine, wilderness medicine. There's a whole bunch of things that you can do. I have a friend that's doing a wellness fellowship at Stanford. So, and it's entirely optional. You don't have to do it. For me, it was just to add to my career and add to my interests, because I didn't just want to practice in the ER. I wanted to have other interests within work that could fulfill, what I find is interesting. So, and you can apply to fellowship anytime after graduating residency. But once graduating, you actually have to take certain exams. You do have to do a written examination, which I took last year, and then most people also have to take an oral boards exam. Unfortunately for my class of residents that graduated, we haven't taken our oral board examination yet, also due to the pandemic, because there's no face-to-face test time. And then after graduating, there are continuing education and recertification requirements that you would have to do. So this takes a long time to get to. And I'm still not done with fellowship yet. I'll be graduating in July. But after you finish, when you are deciding where am I going to work, there are different types of practice environments that you can put yourself in. And sometimes it'll be a mix of these. It doesn't have to be strictly one. I think the ones that we're most familiar with is going to be the academic environment, given that everyone is most likely in medical school. Most of us are associated with a big hospital / school. There are some benefits, at least in the US, to be associated in an academic environment. Usually that means the workplace that you are at, you have there's a research emphasis, so a lot of your colleagues or you do have some research requirement to fulfill. There are much more, usually the practice environment also has a lot more technologies, therapies and specialties that you may not have out in a community environment. And also the other things that here, if you work academically, we also tend to have less pay. That's just how it is here, if that matters to you. And then also, you may not have to work as many shifts because you may have some other academic responsibilities. So there's a program director, if you are a program director of an emergency medicine program here, you may not have to do as many clinical shifts because you have other responsibilities in terms of resident education. Same with if you happen to do a fellowship in toxicology, and if you are a toxicologist, you may not have to do as many clinical shifts in the ER because you have to cover shifts at poison control. So there's some perks and benefits to it. And then the other sort of hospital environment that you could practice in is a community environment, which has a lot less of the research, maybe less exposure to students and residents, but it doesn't mean that there are none. It's just not as robust. And you may not have as many specialties or access to the technology or imaging or medicine. But some people like that. And that's a lot of us, like me, I do a mix of both. I work at the main hospital, and then I work out in Wyoming, which I would consider a community hospital that has some limited specialties. There's surgery, there is anesthesia and OB, but other than that, everyone else gets transferred. It does have all your CT, MRI machines, but there's a lot less in terms of resources. And every now and then we might get an interested student or resident that rotates through there. The other thing that's very common in the US is actually the propagation of urgent care centers. Now, urgent care centers are usually for less acute and sick patients. Usually, like, it can be a standalone. You can find it walking through the city, and it's not attached to a hospital, and it's for theoretically minor complaints like, oh, I have a runny nose, or oh, I accidentally cut myself a little bit and I need sutures repaired. So basically, and a lot of urgent cares may not even have anything more than an x-ray, or usually has no other specialties. So very, very simple problems. And a lot of urgent cares are also staffed by what we have here as physician assistants or nurse practitioners. Every now and then, yes, you do get a very sick patient that goes to the urgent care with a heart attack, and you're like, oh, I have to transfer them out. But this is it's a rather new phenomenon that maybe started when I was in medical school, where it started getting popular. It just so most people like it because they're skipping a lot of the more busy hospital emergency rooms, especially if they're coming in for a minor complaint. Now freestanding emergency rooms are also very interesting. I also practice in a freestanding emergency room in Utah. Usually freestanding emergency rooms, they have all the imaging requirements. So like a CT scan, an MRI, you'll have all the basic equipment, but there's no associated hospital. So if you needed to admit someone, if they needed surgery, if you needed any other specialists, they are not around. Our freestanding emergency room that I work in Utah is just attached to a bunch of outpatient clinics, so the family medicine clinic or the cardiology clinic. A lot of the times, you know, the clinic, if they're worried about something, they may send the patient to the ER for further workup. Like if I was talking to my primary care doctor and I incidentally mentioned I had chest pain and the doctor was worried that I need a little bit of a more immediate workup, they can send them down to the freestanding ER. And then something that's been a little bit more common, especially during COVID, is telemedicine. And it's becoming more popular as of late because it does give people a little bit more time and space to practice medicine from home and be less geographically limited. We've been using this in our urgent care centers sometimes, where they can call in and speak to it, because most urgent care centers are staffed by physician assistants or nurse practitioners. They can do a telecall to an ER physician if there is a contract with another hospital or physician to kind of get advice as to what to do. We also employ telemedicine for, sometimes we do, like in my freestanding emergency room, if I needed to consult psychiatry because I could not send a suicidal patient home. They can call. Okay. So we can also consult psychiatry or neurology from our freestanding emergency room. If I was debating whether or not I wanted to give TPA to a stroke patient, a neurologist can pop in on the screen and evaluate the patient from there and see if they agree with my assessment. So that is something that is relatively new. It's been working well, but obviously it's still not as good as an in-person exam, but it still works well for places that don't have as many resources. Like when I work in Wyoming, the cardiologists used to only come out there once a month, and there's no cardiologist in town. So it does help with some of the access issues. And then this part is probably a little bit less interesting for everyone, is the type of employment models that we have here in the US. I think hospital employees, where you're employed by, whether that's an academic hospital or a for-profit hospital, which we have here, is probably going to be the most familiar to you guys. And that's where the hospital just employs everyone. But we also have other things here, such as democratic groups and corporate medical groups. It gets a little bit interesting. So corporate medical groups, usually at the top of it, who owns these groups are actually not physicians. They're usually for-profit financial groups that buy out hospital contracts, and there are perks and benefits to it. Some people like it because, well, they can become partner and get stocks within the group. And unfortunately, some places only, such as Denver, really only employ corporate medical groups, and Team Health, USACs, Envision, Vituity, that's usually some of the more well-known ones here in the US. Some people don't like working with them as much because you don't have as much say in your employment and model, and you don't get as much voting as to how your group should practice. And then the democratic groups is usually owned by a group of physicians itself. So like all the ER docs are owned by a group of physicians. And if you work for them, after a couple of years, you may become a partner. And partners have equal voting rights within the group as to how you share the benefits, how the hours are split. So all the decisions are made by ER physicians for the ER physician group. There are some mixed models to this as well, but probably less important for you guys to consider this at this point. So unfortunately for us, a lot of us are graduating and technically should be attending soon. COVID, I don't know if this is done the same in Japan, is actually making it very hard for graduates of emergency medicine programs to find jobs. For me, it's been very hard too, and it's not had, the pay offers have not been as high. A lot of academic places are not hiring, which is unfortunate because the average, we have about 2,500 emergency medicine doctors that graduate, as you saw earlier in the slides, and a lot of them have an average about $200,000 in medical school or just school debt, and unfortunately, it just means that, you know, they have less choice in the kind of jobs that they want. And a lot of this is secondary to decreased ER volumes. While you would think that coronavirus has kept everything very busy for us here, a lot of the ER volume has been down from anywhere between 15 to 40%, just because a lot of people are staying away from the ERs. So it seems that, you know, there's a lot of, unfortunately, cut down on hours and the amount of physicians that are needed in these places. Even at the University of Utah ER, while it's getting busier again, it hasn't reached its previous patient volumes yet, which is unfortunate. Okay, let's do this poll here. So I'm gonna try this poll here, and I hope that people can join in. And this might be a hard question for you all to answer, especially if you're not from the US. Knowing what you know about our USA healthcare system, social, economic, and political issues, what are some of the problems you think we see in our emergency rooms that is going to be more common? And I'll give this about 3 minutes. Hopefully it works. It's worked for me in the past, but all the responses are anonymous, so just put in whatever things you think of that we see here in the US.
Wait, so are we supposed to be seeing something, or you're waiting for it to like upload?
So can you see the top of the?
Yeah, I don't know if it's just my computer, but I'm not seeing like the choices. So
there aren't choices. Like, you're just supposed to. It's like a free text that you put in. So
like, gotcha.
Yeah,
okay.
You go in, and then a little word cloud comes up. So if you say,
oh, it's like new.
Yeah,
They add all these cool features on Zoom.
I know, right? But it's kind of a free response. So if you say, I'm just going to give an example, no health insurance. So that's a very American problem. So that'll pop up here. But we also have a lot of other problems. So, but I just wanted to see what people's thoughts and you know, exposures to what we have going on here are. Maybe it'll work, maybe it won't. I'll give it, let's see, I'll give it 3 to 5 minutes from now, and then I'll just move on. Oh, look at that. And the bigger the sometimes the bigger the word is, it just means that, I don't know what that side means over there, but usually the bigger the word, it means that there's people have put more emphasis on it. That's some pretty good ones. Gunshot, sepsis, drugs. Yeah, that's pretty pretty accurate over there. Mental. Yep. Oh, okay. Oh, inequality. Yep. All the things we see here. And a lot of these are public health problems for us. And here in the US, emergency medicine is unfortunately like primary care. It's the first point of access for a lot of citizens here. So, oh, drug. Oh, yay. Oh, expensive. That is true too. All right. Okay. Okay, I think we've gone through most of it. Yeah, wow, these are pretty, so I guess you guys in Japan know how bad we are at at some things. But yeah, these are a lot of the problems that we see in the US, no matter where you are. I practice in New York, I practice in Philadelphia, the suburbs of Philadelphia, and now a couple of other states here. And I have a lot of friends that also say that this is an issue for them. But yeah, one of the, I would say as a developed country, we have a lot of violence. We have a lot of gun violence, which is amazing, weird. I don't know how you want to call it, but a lot of these things come to the ER if you want to look at it. How do I exit my own poll? There you go. Even when you look at it in the US, when we compare ourselves to other countries, this is, look how many times more we have for violent gun deaths here compared to other countries, especially compared to Japan. And it's just because here guns are so much more easier to obtain. The US has the 28th highest rate of gun deaths and gun violence in the world, especially compared to other wealthy countries. Wyoming, where I do work, has the highest number of registered guns per capita of any state in America. For every 1,000 residents, there are about 195 guns. And this is, so it would be about 115 registered firearms with a population of 582,000. So that's a lot. And this is how we also compare to other countries that have rather higher rates of gun violence. A lot of the countries here, unfortunately, have higher rates of gun violence because of drug trafficking and cartels. So if you do end up practicing here, depending on which cities you're at, whether that's practicing or doing training here, you will get a lot of practice with penetrating trauma. And it would not be unusual, like the way I was in Philly, to have multiple gunshot victims that come in at the same time, multiple per night, per week. We have very high rates of, again, depending on what city you're at, it's a little less so in the Navajo Nation where I do also work, but in New York, in Philadelphia, sometimes in Wyoming, you do get a lot of these patients that come in every day. When I was a medical student in New York, we had 41 gunshot wounds that came in just one weekend in September. So you get pretty good at handling your traumas and a lot of the procedures that come with that. And definitely safety is also an issue for a lot of the ER docs. Just because guns are so easy to get in the US, a lot of emergency rooms will have metal detectors to make sure you know patients are bringing it in to the ER. We've had patients, when I was in Philadelphia, while we were coding a patient, someone had a cardiac arrest, and a family member actually pulled out a gun in the middle of all of this because there was a disagreement with another family member whose fault it was that the patient got so sick. So it's a very real problem that we have here, unfortunately, whether that's patients coming in with the side effects of gun violence or just as a threat to the actual healthcare workers themselves. And to just visualize it in another way, this is the US compared to other developed countries. It's a lot more. Hopefully this helps you visualize it. In Utah, I would say that, at least in Salt Lake City, the hospital here, because it is a little bit more isolated, there's a little bit less gun violence than some of the other parts of the city where I work. But interestingly enough, even though we do have a lot of exposures to guns here, if you actually look at this chart, I took off the key, but a lot of the deaths from guns is more from suicide than homicides. So this top line over here actually represents firearm suicides, which has always been higher than homicides. And it seems that a lot of you already know our access to mental health care in the US is not the greatest. We do see a lot of psych patients here. There aren't enough facilities to hold a lot of them, and also many of them don't have the right kind of insurance to get the long-term treatment that they need, and a lot of them end up relapsing. A combination of just having easy access to guns and having poor healthcare access, unfortunately, exacerbates this. And studies have shown, at least in some of the public health journals, and this is in Indiana, not very recent, if you have access to a firearm, and that's part of our screening for our suicidal patients too, is to ask if they have a firearm at home, because it does show that if you have access to it, you're, I also cut off the key for this, but this is the successful, the dark part is the successful death. So the higher the access to a firearm means you have a higher rate of success in failed suicide attempts, unfortunately. So it's unfortunate, but the other part is, I'm gonna just show you, this is like the causes of death worldwide. For most countries, the #1 cause of death is always gonna be cardiovascular disease, and that's the same for US. But if you look at the other part of the data, so cardiovascular disease, if you look at all this, homicide, suicide, drugs are also very high on the list. If you actually look at the CDC data, deaths from overdose and drug-related disorders is actually higher than trauma in the US, which is also very unfortunate. So here we also have access to many different types of drugs. More lately, at least, what we've been facing here is an opioid epidemic. It is a public health problem. And people say that around maybe 1999, when here we've included pain as a 6th vital sign as part of your evaluation as a physician here, there was an increase in opioid prescriptions. And at that time, a lot of the pills were marketed as non-addictive, very safe. So more and more of those got into the market. Unfortunately, they did end up being addictive, and people ended up, after physicians stopped prescribing as much opioids, these patients that were addicted eventually had to turn to heroin to soothe their addiction. And then eventually, because synthetic opioids were cheaper to make, the number of deaths from synthetic opioids also increased. And a lot of it was also because people didn't know what was being mixed in there, and it was a lot stronger than what they've been used to. So when I was in residency, carfentanil was something that was new on the streets, and a lot of people died a lot quicker, and they needed many more doses of Narcan. And a lot of the law enforcement was very much like fearful that if this even got on their skin, they may die from it. But there's a lot of things that, again, in the US make this a problem. Is one, poor access to mental health care, poor access to regular health care, and then there's just so much stigma around it. And then other things that add to this is we also have a lot of homelessness here. And when you don't have a stable environment to go home to, you're kind of exacerbating a lot of the problems too. And then interestingly enough, these are a lot of the, it's always in the news. The Sacklers own Purdue Pharma, and a lot of their negative press has been like they introduced this to the public and didn't stop the overprescription of opioids and touting it as non-addictive. Over here, this is actually a picture from Philadelphia. It's known as one of the biggest open-air heroin markets or opioid markets on the East Coast, meaning just on the streets you can buy the opioids that you need. And a lot of people end up coming to that neighborhood and just not leaving. They'll come in visiting from another place, hoping to get some of the drugs, and unfortunately never leave because it's so easy to get there. They're addicted, and it ends up being a hard cycle to break. And we saw a lot of this in residency too. So let's see if I can play this next video here. Hopefully.
In Philadelphia's Kensington neighborhood, City Councilwoman Maria Sanchez is trying to rid her community. In Philadelphia's Kensington neighborhood, City Councilwoman Maria Sanchez is trying to rid her community of prescription opioids and heroin.
When I have 1,200 doctors writing script in this district, that's a problem. It's something that's been spiraling, and now heroin is so potent, you just have the perfect storm.
Kensington has a long history as a heroin epicenter. Now so-called pain clinics have emerged. Fraudulent practitioners overprescribe opioids that are diverted for sale on the black market. It's an area where those addicted to opioids come to buy and use.
Prevention Point is an agency that...
Patrick Traynor is with the Drug Enforcement Administration. He says users here can find some of the cheapest and most potent heroin in the country.
There's a lot of independent drug traffickers. They're all competing for the same customer dollar. That's part of what maintains and keeps the purity levels of heroin so high.
Addicts come to Kensington from far away. With little money, with overpowering addictions, some stay in the neighborhood. Sarah, who didn't give us her last name, is among them.
I don't know, something always calls me back here. My mind just tells me to come back here. I don't want to, and I cry a lot, and you know, it's a lot of guilt. That's the other thing. Like, you feel guilty, and then you can't deal with the guilt, so then you get high to deal with the guilt.
Philadelphia is just a microcosm of a much bigger problem.
Gary Tuggle, who had...
So this is a big problem, and I'm just going to stop the video because it is a little long, but this is a big problem in Philadelphia. They, a lot of the addicts, unfortunately, it's hard for them to get the help they need. And along with the heroin use, there's a lot of comorbidities that come with it. So we do have a lot of, because it is IV drug use, we do see lots of higher rates of HIV, hepatitis, endocarditis, just because you're not using clean needles. There are efforts to open safe injection sites where people are able to inject. They open areas where people can inject with clean needles, and that way at least you are preventing some of the other complications that can come with it. A lot of ERs here have also if you do ever end up practicing and training here, also have bridge programs, like starting with a lot of patients on Suboxone before discharging, and that way they can hopefully, with the medically assisted treatment, be able to detox. Unfortunately, with the coronavirus, again, coronavirus exacerbating all the weaknesses in our health system, kind of have made it harder for a lot of people to get the treatment that they need. In July of 2020, deaths from drug overdose in the US rose by about 13%, which is a lot higher compared to, well, 13% compared to 2019. And there are also a lot of addiction treatment centers that haven't been able to provide the care that people need. And then worse housing stability for a lot of patients as well. And it just makes everything a lot worse, unfortunately. And then, of course, everyone knows that we have a terrible, terrible insurance, health insurance coverage here in the US. About, if you don't count the elderly, who qualify for Medicaid, about 12.9% of adults don't have insurance, and this is just a racial breakdown, but a lot of it also brings it to other things. We also see a lot of people put off their healthcare needs and then end up having more complications. So if we go back to the US here, we have a lot more complications, diabetes, and subsequently also kidney disease. A lot of people are on dialysis here. There's a lot of people that come in on DKA because they can't afford their medications. They have a lot more complications from this, especially also cardiovascular disease from it. So you get a lot of sick patients here just because they can't get the medicine or care they need. And this is just Japan for reference. Well, this slide didn't come out the way it was supposed to, but here we also have a lot of, unfortunately, things. Your social determinants of health here is also kind of affected by race. Unfortunately, here in the US, we know that Black Americans or minorities do not get the care that they need, whether that's access to health insurance. There's discrimination and pain medicine that people receive when you're Black. There is a delay in EMS travel and transport times for Black communities compared to white communities. There is worse maternal mortality and infant mortality rates even after you've adjusted for education levels and income levels in the US. So there's a lot of things that persist till today, and that's why we have a lot of these protests and whatnot. And that also permeates to what happens in the US. So, for example, African Americans have higher rates of blood pressure, diabetes, stroke, compared to their younger counterparts. And then combine this with the coronavirus epidemic, where these are risk factors that, especially high pressure and diabetes, that make your conditions worse. They are at a higher rate of complications. This is how not well we're doing in the US. This is the number of cases we have in the US in terms of coronavirus, and it's increasing every day just because we don't like to follow any mask protection rules here. I think Japan is close to 260,000 or so. I think the state of Utah alone has about 301,000 cases. The US, there you go. Utah's a little bit lower. It's about 301, so you can't see the state. This is by county alone. So the other place I also work is the Navajo Nation. This is a reservation that is the largest in the US. Back when we, unfortunately, settlers colonized the area. They do have their own government and act as a sovereign nation, and also at the same time theoretically is supported by the US government, although largely neglected. Here on these, unfortunately, they do have a lot of under-resourced medical settings. If we zoom in a little bit closer, I work over here in Shiprock, which is in New Mexico. And this is just a little video too, just so you can kind of see what the environment is like. But,
the Navajo Nation is in a health emergency as COVID-19 cases spike for a second time. Strict curfews and a mandatory mask policy The Navajo Nation is in a health emergency as COVID-19 cases spike for a second time. Strict curfews and a mandatory mask policy have only gone so far in stopping transmission on the largest tribal reservation in the country. Stephanie Sy spoke to 2 doctors on the front lines treating Navajo patients, even as hospital capacity runs out. The Navajo Nation, home to more than 170,000 Navajo, is under a 3-week lockdown that ends on December 6th. That means non-essential workers must stay at home unless there's an emergency or an immediate need for food. Since COVID found its way to the vast territory that spans parts of 3 states, more than 600 Navajo have died of COVID-19. And in recent days, daily positive cases have reached an all-time high. The Navajo president, Jonathan Nez, says the uncontrolled spread of the virus is impacting all communities on the Navajo Nation, including Gallup, New Mexico, where Dr. Daniel Mays has been seeing COVID patients at the hospital where he works. Dr. Mays is a fellow with the University of California, San Francisco's HEAL program, which has helped to provide healthcare on the Navajo Nation since 2015. Dr. Mays, thank you so much for joining us. Describe what you're seeing there in Gallup, New Mexico. Are you seeing another surge, as in many parts of the country?
Absolutely. What we're seeing is both a surge in new cases, new diagnoses of COVID-19, as well as hospitalizations. What we saw in spring was a wave. What we're looking at right now looks like a tsunami.
I know that area hotel rooms were being used to isolate COVID-positive patients from the Navajo Nation. Is it true that those rooms are also being used as de facto hospital rooms?
Yes, this is a huge source of stress. The reality is the health system here in Gallup and many other parts nearby is just too weak to begin with. When you introduce a pandemic like this, it puts too much strain. You're putting people in the hotel who should be in the hospital. I think our biggest need right now is staffing and space to provide care. If we could get a huge influx of support for those things, I think we have a lot better outcomes and we would save lives.
Are you also, in order to free up more beds, perhaps having to release people earlier than you might ordinarily want to?
Absolutely. We are having to discharge patients at a much more aggressive rate, sending people home. Many folks in the Navajo Nation don't have great home infrastructure, unfortunately, and that's due to decades, over a century of socioeconomic exclusion. And we're trying to think about a safe home discharge plan. We run into barriers, sometimes all the way down to someone not having electricity for the oxygen machine. There are chronic issues facing Native people, both here in Navajo Nation as well as the surrounding Pueblo tribes and across the United States. Right now in the state of New Mexico, Native Americans account for 23% of COVID cases, 41% of COVID deaths, but they only make up 10% of the state's population. And that's not a statistical anomaly. This is inequality killing Native people. And that is something that needs to be responded to immediately to prevent more loss of life.
Dr. Daniel Mays with the University of California, San Francisco, joining us from Gallup, New Mexico. Thank you, Dr. Mays.
Thank you.
We turn now to Dr. Sofina Calderon, the Deputy Chief of Staff at a tribal hospital in Tuba City, which serves a 6,000 square mile area on the northern Arizona side of the Navajo Nation. Dr. Calderon, thank you so much for joining us. I know your hospital has been at capacity since May, when that area had one of the highest COVID-19 infection rates in the entire country. Are you experiencing another surge now?
There is another surge going on right now, worse in numbers right now compared to what we were experiencing in the spring. So we are really buckled down, working very hard to really get ahead of this, but it's becoming quite overbearing, and the numbers are increasing every day.
I know that a nursing shortage is a chronic problem at rural hospitals, including yours. Is that a continuing issue?
We do have a very huge nursing shortage. Back in the spring, we were surging while the rest of the United States was okay, and we were able to get a lot of nursing help from all over the United States. But now it's a huge problem because everywhere across the U.S. is surging, and we can't pull nurses from other places where they're already needed.
The Navajo government, as you know, Dr. Calderon, has enacted very strict protocols for gathering. There aren't a lot of bars and nightclubs and restaurants on the Navajo Nation anyway, and there's even very good contact tracing compared to other places. So what do you attribute the continued transmission of this virus on the Navajo Nation to?
So most of our contact tracing is leading us to see many spread in many areas in terms of family clusters and family gatherings. So birthday parties, funerals, especially here in the Navajo Nation, funerals are very, very close-knit, and people gather in small spaces and grieve together on a continual basis several nights in a row. And it's just sort of a traditional way that we carry out and mourn. And so there are a lot of gatherings still happening.
Is part of the problem that folks are still going off the Navajo Nation where protocols aren't as strict and coming back into those family gatherings and bringing the virus with them?
Yes, I do believe so. We don't have extensively large grocery stores and places to get supplies for things for our homes and for our families. So we have to leave the reservation sometimes and be able to do some of our shopping off the Navajo Nation. All the restaurants are open still off the Navajo Nation, and you find it a little bit harmless to be able to eat in a restaurant and then come back home back to the Navajo Nation and then not know that you might have brought the virus back.
You are Navajo, of course, and you were actually born in the same hospital where you are now a physician.
So a lot of the things that make the problem worse is the Navajo Nation does cover a lot of space. It's about the size of West Virginia. Some people have to travel 120 miles to even get groceries. They live in multi-generational housing. It's hard to isolate. And at baseline, there are really high rates of diabetes, lung problems, substance abuse issues, and a lot of just distrust for medicine. So it does make it very hard for the community to keep the spread of the virus from getting worse, because a lot of people also work outside and off the reservation too. They have poor access to water, electricity, internet, to find updated information. So that's part of what makes everything harder for them. And a lot of the hospitals there do not have a lot of resources to begin with and get very little money from the government. So we can talk about COVID and what we've been doing, but what kind of treatments are you guys using in Japan for your COVID patients, or anywhere else if you don't happen to be in Japan? And we'll keep this to 3 minutes. We'll just keep it short. Okay, well, I'm going to move on to what we do here at least. Supportive care. So, so at least in the University of Utah, not necessarily in Wyoming or at the Navajo Nation, part of when they come through the ER, patients are screened by their if they have respiratory symptoms or symptoms of coronavirus, which may include just hypoxia. If they have a fever, they get moved to a dedicated area in our ER, separate from our other patients, just to limit the spread. Obviously, there can be asymptomatic patients on the other side, but we have a dedicated side for people that even have a small chance of having the coronavirus. That way we can minimize the exposure. For us, we are trying to avoid the early intubation, as it's been shown that that's not been beneficial for the patient. So we do employ other things such as the regular nasal cannula, the venti mask, the high flow nasal cannula, and BiPAP. For patients, obviously, we're also trying not to admit as many patients as we can. For patients who do happen to be hypoxic, maybe to the 80s, 88, 89, 85, we do try and send them home with their home oxygen, with an oxygen tank that we've gotten for them here, as well as a pulse oximeter. There are certain requirements that we have, such as they have to be English speaking, they have to have running electricity at home for the oxygen, they have to have no other significant comorbidities for us to be willing to do that. And the other thing is, if they are going home, and because we have a very high homeless population in Salt Lake City, we do have to make sure that we're discharging them into a safe environment, because if we can imagine, if we discharge into a shelter and they're COVID positive, that is a very vulnerable population that one is going to get sick and sort of also spread the infection locally. So here what we have had is if someone tests positive, if a shelter does not have a localized area for their COVID patients, we actually do send them to a hotel. And at this hotel, there is a nurse that can do basic check on them every day, make sure their oxygen levels are okay until their quarantine period or their symptoms have resolved. And for our patients that do get admitted, we do have rapid COVID antigen tests for people who need more emergent surgery, let's say. But we also have the traditional PCR tests and combined with the other viral panels, which make sure the influenza and other sorts of viruses like the rhinovirus and whatnot. In terms of our inpatient treatment, our inpatients actually do get remdesivir. They get 5 days of it, but it has to be started in conjunction with our infectious disease team. We do start patients also on dexamethasone, especially the ones that are on mechanical ventilation. That's where at least the studies have shown that it's been the most beneficial, is the sick COVID patients. And we do not need ID guidance for that. Convalescent plasma is also something that we do in the hospital. Again, we also have to contact infectious disease to start this process. And in terms of the monoclonal antibodies, we do not do that in the hospital, but there are outpatient clinics in areas that do start them, and we may get a patient in the ER that came in possibly for like a side effect to screen for. And then some of the other treatments that people have used in the past, these are the ones we do not use because they have not been proven to work. Some of the other hospitals I work at, they will not have all of these other, we do not do remdesivir or the convalescent plasma in Wyoming because we just don't have that out there. And then the University of Utah also does a lot of telehealth with some of these other outside hospitals, such as providing ICU physician coverage for some of these smaller hospitals where they can call in and whatnot. These are just some of them, but I don't have any, unfortunately, any more detail as to what kind of services and how often we provide them. It is just an availability. In terms of resource allocation, which you've heard about probably a lot in New York, and we haven't reached that stage yet, we do have a university-wide protocol that kind of dictates if we do run out of ventilators, if we do run out of resources, how are we going to stratify this. And a lot of this is done by, well, depending on how sick the patient is. If they are DNR, DNI, yeah, they're not going to the ICU. No, they're not getting intubated. Or if they have a severe injury along with, their sickness, fine. They are not going to be intubated. They're not going to go to the ICU. But otherwise, depending on the needs of the hospital, we do use an MSOFA kind of calculation to decide whether or not to give them more treatment. And this is also a little bit flexible here. We start with an MSOFA greater than 11. That's someone that should be considered to transfer to comfort care, non-ICU care, or someone that's 8 to 11, has a score to 8 to 11 and seems to be increasing. But these thresholds can be lower depending on how much resources we have. So it may be that later on, hey, maybe a score 8 greater than 8, we should automatically transition into non-ICU care. We haven't needed to ration care like this yet. We do have special considerations for pregnant people, age, and if you're an essential worker. So if you have 2 people with the same score, you may give priority to the one that is younger. Same with an essential worker. If there's a physician that's sick, they also get priority over someone that may have the same score. They do something similar at the Navajo Nation as well. Unfortunately, I covered that part, but they do an MSOFA score, and then additionally, they also screen. They give 2 points for anyone in this column over here, and 4 points for anyone in this column over here. And then depending on where you fall, you're either the highest priority in terms of getting resources, intermediate, or lowest. So that's at the Navajo Nation, and this is something we've actually had to do in New Mexico. So depending on the day. So yeah, that is an area where we've had to use it. Out of hospital cardiac arrest, usually if there's nothing that is clearly reversible, like a pneumothorax or a tamponade, usually 20 to 30 minutes of CPR. Sometimes people even only do 1 round and recall it. And sometimes we will not even bring the patient into the ER. We tell them to call outside the hospital, or we'll do an evaluation in the trauma or ambulance bay to avoid exposing anyone in the ER for possible coronavirus. So not as much of an issue here yet, but my friends in New York, that was something that they had to do, or they just wouldn't even do with CPR. And we are not as aggressive as we were before. We used to do TEEs and cardiac arrests to look for other reversible causes and whatnot, but we've kind of stopped that. These are some of the things that we've also been doing. We use an aerosol, this plastic tent thing, to hopefully decrease the number of aerosols that everyone is exposed to. This is just a training, but since these people here are not in PAPRs, but we are ideally in a negative pressure room, viral filters, PPE, and we're using video laryngoscopes to kind of help guide us in all of this. And then we're also rolling out vaccines. I got my 2, and I got mine on the 7th, so I'm fully vaccinated now. Our ER and ICU workers had the first round, and then the rest of the hospital got the rest. We are rolling this in some parts of the community. In the Navajo Nation, a lot of the Navajo elders have gotten their 2nd dose of vaccines already. And out in Wyoming, they have also started rolling it out for the community for older people who are have some comorbidities and also ambulatory. They are also in line for the vaccine now that most of the healthcare workers have already gotten it. And just a little bit back to emergency medicine, we do have a lot of rate of burnout here, 59% compared to other specialties. A lot of this may be because, I skipped it, just because of the trauma and the sickness that we do see. And then at least when you're breaking it down by gender, unfortunately, a lot of us, for females, they tend to have a lot more rates of burnout just because of support at work, whether you get time off for work-life balance and time off for pregnancy and whatnot, which is unfortunate. It's still an issue here. The other unfortunate aspect here in the US, emergency medicine still has a small representation of women in the workforce. In the medical schools is about 50-50 now, male to female. It's still about 25 to 36% for
females in emergency medicine and also in leadership positions. And then I just thought to include a racial breakup of emergency medicine doctors here. After Caucasians, actually Asians do make up one of the larger, as a composite as a whole, make up one of the larger minority groups within emergency medicine. Unfortunately, there is very little data as to how much of us are in leadership positions traditionally in other academic roles and other companies. They do talk about something called the bamboo ceiling, where we do make a lot up of the educated workforce or the corporate workforce, but do not make it up to a leadership position. And I wouldn't be surprised if in emergency medicine that is also the case for Asian American or Asian doctors too. And that's it. I know it kind of went long, but it's such a broad topic. So if you had any questions about any more details, I can also share that. I was trying to touch on a lot of things here. You can ask me now. You can ask me within an email. Up to you guys.
Thank you so much. It's a lot of subject you cover.
Yeah, it's a lot of information.
Many darker aspects of the United States, particularly in emergency medicine, but in Japan, things are a little bit different. But I think some question may come up, hopefully. Anybody want to ask a question?
From the audience. So I received one question from the audience. It says, "Thank you for your great lecture. I really like your passion and your past achievements. I'm also interested in improvised medicine and limited resource settings, such as the global health field. Do you think those experiences, such as humanitarian works and volunteers in lower middle-income countries, can be beneficial for matching to residency?" That was the question.
I think so. You can always, I think what residencies look for when you do apply to programs is that you're adding diversity and experience to their program, because everyone that applies is going to have at minimum the same test scores and everything. What you're doing is, it's not just how well a person is going to fit into the program, but what they're going to add to the program, how they're different and how they're going to contribute to the program that no one else can. So I do think that experience in more under-resourced settings is going to help. And I do find that sometimes it does help when, sometimes I'm in low resource settings and I don't have the things I need, and some of those skills transfer through, same with equipment and the way that you practice. And I'm sure that when certain hospitals get overwhelmed, unfortunately, you do have to use a lot of the principles that you have in other lower resource countries. So it is always going to be an asset.
Thank you. Was that okay?
Yeah, did you want more info on that? Like, even like for CPR, when to how much care to give, how much to drag it on for. Like in other countries, there's no, like I rotated in Uganda. There's no such thing as, hypothermia protocol for your post cardiac arrest patients. They don't do more than, that, just because there's no aftercare, but for us in the US, it's always do everything, and it may not even have a meaningful neurological outcome. So there's a lot of principles I think you can apply from other practice environments to here. Is it worth it for us to keep trying to prolong life with all these extra interventions that may not make a difference for the, livelihood of the patient, So
I have one question about the burnout.
Yeah.
Because we call American style ER system, we call it a North American ER system, which is different from the Japanese style, because you work as a shift, right? Like a 8-hour shift, a 12-hour, 6-hour, and so.
Well, there's 24-hour shifts too at some places.
But once you take off, you are completely off work, right?
Mm-hmm.
But in Japan, many places, it's like even the people who is working in the emergency room, there's no like a on and off, like a shift system. So actually, they may burn out more, I thought. But how do you think American style?
Oh yeah, I guess it depends on how you look at it and the type of practice environments that you have. So for me, someone who is in academics, I'm a little bit more shielded from burnout because I find meaning and fulfillment in teaching residents. I think it adds to just seeing patients back to back to back. You know, I have time to teach. I have my global health work that I do that I find meaningful. So in an academic environment, I feel like those add on to your purpose and decreases burnout. But outside of that environment where a lot of my friends may practice, there are different requirements that they look at. Let's say if you work for a corporate medical group, a lot of the times it's metrics that they also look at for you, and which affects your pay. So like patient satisfaction scores, which is kind of important here, that can affect your pay. How many patients you see per hour, how many procedures you generate per hour, that also affects it. So there's a lot of things that can contribute to it. And also like we have a little less say, we do a lot of documenting. We have a high rate of people that sue us. I don't know if that in Japan it's like that, but here sometimes the medicine that we practice here, it's not what's best for the patient. It's practicing, well, what do I do so the patient doesn't sue me, which is like very different. And even if you do everything right, someone can also still sue you. Like I actually have a case. I had a case in the past where a patient said I didn't fix the fracture, but technically I'm not supposed to fix the fracture. I'm supposed to stabilize the fracture so that the orthopedic doctor can fix it, right? And they were not happy with that outcome, said I couldn't fix it, and it became a whole mess. So there's a lot of things here. I don't know if it carries through to what happens in Japan, whether that's the EMR system, metrics that we're held to, a lot of sick patients that come in just because they don't have medical care, a lot of violence here, a lot of just, unfortunately here is also, I don't feel like I'm helping my patients out sometimes. I feel like it's a temporary fix. Like I'll see them for their withdrawal symptoms and I'll help them with that. But at the end of the day, when I discharge them, you know that they're going to come back the next day or afterwards, because at the end of the day, what they do need is a regular doctor, a detox program to keep them out of the hospital. A lot of the times people do not have the resources, and you know that you're not, at the end of the day, helping them as much as you can. So maybe that's very different from Japan, but we see a lot of our patients regularly in the ER, even though that's not supposed to be the normal.
Thank you. I'd like to ask Dr. Oya what he thinks.
Yep.
ER director.
Yeah. This is a huge topic here in Japan as well. And one thing I really, I can say, I think the big difference between the Japan and the US system is that even though in the States, the system work is, established, but the situation for the emergency physician in the state is, always monitoring and high responsibility. So those kind of pressure is so high compared to Japan. So even though the shift or working hour is short, but it's going to be a huge pressure. So the burnout percentage is a little high. But here in Japan, we worked harder and we fortunately survived right now. But the pressure is compared to the States, it's not so high, I guess.
Yeah, I guess it's slightly different. I feel very happy doing the 8-hour shifts, but then when I do the 12-hour shifts, it's also very hard for me. I have friends that do 24-hour shifts in other hospitals, and when it does get busy, it's very hard for them too. So, and then depending on the kind of responsibilities you have, people do unfortunately have work outside of their shifts too. They have other administrative responsibilities. We get a lot of emails here if we don't meet our sepsis requirements for our patients. Like, why didn't you give antibiotics within the first 3 hours? If you don't give fluids, 30 cc's per kg in the first hour, we have a lot of things where we get angry emails that we don't do right. And
I think it also contributes to the burnout.
Let me ask one more question. In terms of purpose for going in the residence program in the States for IMG, international medical graduate, I think that there's a certain difference between the Japanese and other Asian or other from other countries. I mean, the Japanese physician or a young doctor want to just experience the residency program. I think that the Dr. Machi or the Dr. Kumiko will be extraordinary case, but in roughly speaking, the many Japanese young doctor want to just experience the system in the States. And after finishing residency over 2 years fellowship, they going back to Japan. But I think Chinese or Korean physician has a kind of different perspective. So tell me your perspective or the Chinese physicians.
I think it depends. So yeah, I do think that, because I do have some ER friends that are Japanese, and they do their goal is eventually to go back after experiencing the medicine here, just because you see things differently here, and they want to bring that back to Japan. I don't actually know that many Chinese ER doctors that are from China applying to here, so I don't actually know what ends up happening to them. I do know that a lot of other, let's say myself, like the Central American or South American colleagues, they do end up staying here, at least from what I've seen, versus going back home. So I wish I can say more, but I don't really have enough experience with that to know. And I do have one attending that was from Japan, and she did a pediatric residency here, and then eventually did another emergency medicine residency here, and stayed here because she met her husband. So, but yeah, I think it's an interesting thing to look at, but I don't know enough about it.
Thank you.
I received another question from the audience. Thank you for the lecture. I heard that in the States, there is a lot of tedious paperwork that is needed to be filled out by the physicians to turn into the patient's insurance company compared to Japan. What is that like, and could you elaborate?
So that's usually more of a primary care setting that it does happen. Usually in the emergency room, you do have some of that, but not as much. So when you are in a primary care setting, you may have to fill out a lot of paperwork to get certain kinds of medications for patients, or that, let's say it's not a generic medication. Like I know my primary care doctor has to fill out another prior authorization for getting these certain medicines too, and it's just an extra step. And when you do talk to the insurance company, it's not another doctor at the end of the telephone line. It's just some random other person, and it does get very frustrating, because if you're the patient's physician and you think that that's the best medicine for them and that's what's worked for them, then that should be enough to get them their medicine. But a lot of times it isn't. Fortunately, in the ER, a lot of the times, we don't prescribe medicines that are what I would say esoteric. Antibiotics, it's very easy to write prescriptions for. They're very generic. Or pain medicine, you don't really have to do prior auths. So we are able to get a lot of the medicines for our ER patients. And we also have a pharmacy that will, at least at the university hospital, we do have a pharmacy that's attached to the hospital, and we'll be able to get the medicines to the patients before they're discharged. So in that kind of setting, you're able to do it. So it really depends. And usually if you do, for our main hospital, let's say if they can't afford the antibiotics or can't afford the medication, it's packaged into their whole ER bill, and they don't have to pay. It gets a little tricky because sometimes people never pay their ER bills. So technically it's kind of free, but someone else pays for it. Like the hospital ends up paying for it. So it gets a little complicated, but from the ER standpoint, I don't have to fill out as much paperwork as one of the other doctors. Like if I needed to, for COVID,
discharge someone home with an oxygen tank, I just call case management and they do it. But from a primary care setting, that's a little bit harder to do. That they have to arrange those things themselves. So from an ER perspective, it's easier.
And another question. This COVID is a big issue for all over the world, and particularly in the ER is like a front line to fight with the patient with COVID. I know there's a lot of problem, difficulty you face, but also, what did you learn from this disease? In terms of the future, healthcare, and this is people said one very rare infectious disease out of 100. The last one is a Spain flu 100 years ago. So from now on, as a ER physician, what do you think? What you learned from this disease?
I guess it, initially when all of this happened, I was like, wow, what a weird time it is to be alive during a pandemic. But at the same time, I'm grateful for being able to make a difference in a time like this and still having a job and to be able to contribute back. And I wouldn't say that's a medical knowledge that I'm accumulating, but it's just sort of an appreciation for what I'm able to do and the skills that I have, and still being able to do that. At the same time, it's kind of crazy to see what we can do together as a society when we put wow, look, it's less than a year and we already have a vaccine that's like 95% effective. Like, if people actually work together, how much we could actually accomplish, whereas in the past this would take forever. And you wonder like what we are capable of as a scientific or medical community, but then you also wonder, wow, this could have been the outcomes could have been a lot better if we also cooperated in some public health social distancing and mask wearing. But I guess it goes both ways. And it also really makes me very hyper aware of the weaknesses in the US health system, especially COVID exposing that, whether that's the racial, gender, and health disparities that come out of it. Because whatever was there before, it's definitely worse now. And it brings attention to having the importance to going about fixing it. Yeah.
I think all of us learned a lot from this experience, and hopefully that's going to be helpful in the future in healthcare in United States, Japan, all over the world.
Yeah, I mean, it's very interesting because, patients that I normally would use to admit to the hospital, I would just discharge home now. Like your chest pain patients that come in and that you might admit for an inpatient echo and a stress test, you end up discharging home so that they can just get it as an outpatient because you're trying to conserve hospital resources. It's interesting to see what we eventually are able to also cut back on in terms of the way that we practice. And I don't know, theoretically, I can see it going back to the way it was.
I received a question from the audience. Thank you for your lecture. I'm a medical student in Japan interested in critical care. I heard that in the US, both ER physicians and internal medicine physicians can go into critical care. Are there any differences in what the ER critical care physicians and the IM critical care physicians do in terms of critical care?
Oh, so there is more than just those two ways to get into critical care. You can actually get into critical care through internal medicine, emergency medicine, surgery, and anesthesia. They do have slight differences in the fellowship aspect and the training of it. Usually, if you go from an internal medicine aspect, you also focus on pulmonary. So you get a pulmonary fellowship too. So pulmonary critical care. Surgery, you get a surgical critical care fellowship, and a lot of your times is in the surgical ICU versus the medical. Here we kind of separated out. There's a surgical ICU and a medical ICU. So you can go through that route. From an emergency medicine perspective, it is interesting because you can apply to both the fellowship. So you can apply to the ones on the, they're separate applications: surgical critical care, medical, like the pulmonary critical care, and then anesthesia critical care. So an anesthesia critical care is going to be close to the surgical critical care. Usually they work in the SICU. So because emergency medicine usually doesn't have their own fellowship for that, but you can apply through the other routes. There's also a neurocritical care fellowship that you can apply through from emergency medicine residency. So there's a lot of ways to get to it. I think it just depends on what you want your background strength to be. So if you want to be, because obviously if you're training in internal medicine, your background is going to be very different from someone who is baseline trained in emergency medicine or anesthesia. So it just different strong points and what you seem to like more. I do not like rounding. Like you do in medicine, I hate rounding. I would never go through if I had to do critical care, I would not go through the internal medicine route because I would have to do 3 years of rounding. So that's why I'm in emergency medicine. Well, part of it. So yeah, and I wouldn't go through the surgery route. So yeah, you kind of just pick and choose what your favorite is, and you can still get to the same end goal.
Thank you. And I see a hand up, so I'm going to go ahead and unmute.
Hi, can I ask a question now?
Yeah.
Thank you.
Yeah, go ahead.
Thank you for the great presentation. And I got interested in the problem of indigenous people. So what were the difficulties you faced in the Navajo Nation, especially in this COVID pandemic, and when you provide medical care to them?
Yeah, so it's very interesting. A lot of the times out there, you will find, at least in emergency medicine, a lot of the stuff is not the medical part that's hard, because the medicine, you know, right? Like if you know that a patient is hypoxic or infected, you know how to treat that. You know that they need oxygen, or you know they need fluids and antibiotics. That's the same everywhere you go, right? Whether that's in the US or in Japan, it's all the same, or in the Navajo Nation. What makes it hard for me, or at least I thought, was the social and cultural aspects of it. And the, like, for example, a lot of the families out there live in poverty and really big family, like there will be like 14 people that live under one house, you know, or one trailer home, and they still don't have a lot of good resources. I had a patient that 4-year-old that came in that was unfortunately part of a non-accidental trauma. Mom's boyfriend was fighting with mom and threw a beer bottle, and it went through the car and hit her in the face, that she had such a big complex laceration deep right above her eye. And usually superficial ones I could fix in the ER, right? And maybe some more complicated ones, but when it starts to involve the muscles and it's cosmetic, right? If you can't close your eyes properly because of the way the eyelid is, then that's not something for me to fix in the ER. But also in that hospital, we don't have plastic surgery, right? Or any sort of more specialized facial surgeon. So then it becomes the aspect of, okay, so we need to get her to a place that can take care of that. And the closest pediatric hospital is 4 hours drive away, right? So then you can't transfer a pediatric patient by yourself, right? You have to have an adult with them. And the mom pretended to go to the bathroom and escaped from the ER because she was actually drunk at the time and she was going to be arrested. So she pretended to go to the bathroom and left the ER, and the 4-year-old was just there by herself. And we had to call around to family, but then her grandparents, who are legal guardians, don't own a car, don't speak English. and is legally blind, and then like you couldn't find anyone to accompany her, and then we had an aunt eventually agree, so we flew her out, and then the aunt never even showed up to the hospital the next day. There was a lot of social situations where I had this one really sick COVID patient that we could not find, that was too sick for our ICU down there, because we can't do dialysis, we can't do CRT at the ICU over there, so we had to transfer out. And we had to transfer out to another hospital that is also about a 5 to 6 hour drive away. We fly them out, but she got so sick before the flight paramedics came to get her. She was on 4 pressors and maxed out by then. And again, that's not a medical care issue, it's a social issue. Is it worth it to transfer her by flight where she could pass away mid-flight or when she gets to the other hospital? And then have family who may or may not have a car or a way to get there to pick up her body. Like that, those are like weird things that you don't ever think you would need to think of. So I ended up actually telling the flight medics, never mind, don't take her, and having the conversation with family about just ending her supportive life care in our ER instead of having her pass away at another hospital like 5 hours away. So it's like not really the medical care that's hard, it's a lot of the social economic things in place that make it hard and that you don't think you would have to consider when you're in a city, you know, where you have a lot of resources. Yeah.
Thank you so much. Yeah. I can't believe such a messy family or social problem, but yeah.
Yeah, it's
that was really helpful to learn for me. Thank you.
Yeah, it's very interesting. Like it's just things you just don't think about normally, you know, like even having electricity for their oxygen or anything like that, or just getting sick. Or we see like pathology that we don't see normally. There's a lot of hantavirus out on the reservation. That was stuff I only read in textbooks when I was in medical school, but you know, they live in a kind of environment where we get exposed to the rodents that do carry the virus, or they have, there was a lot of uranium mining out in the Navajo Nation area during the war, where they used a lot of the uranium for weapons and whatnot, or energy. And at that time, they didn't tell the people, yeah, this radiation is bad for you. So they actually contaminated a lot of the land, and the water there is actually not safe to drink. And a lot of the miners out there have what they call uranium lung. They have a lot of fibrosis. So at baseline, they have poor lung function to start with. So when you have something like COVID hit the community, you're like, your lungs are already so bad, and now you have a respiratory infection. Like how, like you're going to do worse. And this is not something that other people in the US have to deal with, you know, because they're not uranium mining. Same thing with the hantavirus, where it also usually presents as a pulmonary infection, right? So you're trying to figure out, oh my goodness, are they throwing up blood and coughing up blood because it's hantavirus, it's COVID, it's something else? It just like, they just have baseline more in different medical problems that you normally don't think of or have to think of as well. But yeah, it's a interesting place to work. I like working down there. It's very different.
Thank you so much.
Yep.
Any other questions from the audience? We have medical students, ER physicians.
Kumiko Sensei, anything you want to say?
Well, I mean, you know, I can oversee Jane, so I wanted to let everyone else ask questions.
I'm probably more familiar with what's going on around here anyways.
Yeah, but you know, the COVID numbers in Tokyo is increasing, you know, the last 1 month. And I think a lot of the hospitals there's overwhelmed. How do we, I mean, I know you said like screening, you know, you guys screen patients based on the symptoms, but like let's say like you guys are overwhelmed. There's so many patients coming just because they have cough or something. Like, how do you screen? Like, do you tell them to, hey, get tested outside, and then if you're positive, like what do you do? Or, you know, like how do you screen that?
Oh, so here at Utah, at least, the University of Utah, we have screening tents for people who think they're specifically worried about COVID. So they'll go to these tents, they'll get swabbed, and they will still get screened. So if like the nurse over there finds that this patient just has a runny nose and gets swabbed.
Oh, so you let them come to the ED. I meant like, you know, if they come to the ED, it's gonna be like spreading everywhere. So do they have to call the ED before they come to the ED, or they just can just, it's a walk-in?
So initially we just had a COVID tent that would just do all the screening, and then if they were worried about COVID and if they had abnormal vitals or it said something like, I have the worst headache of my life, or I have this chest pain, then they get diverted to the ER. If they're just coming for a swab, they can entirely just not go to the ER. Initially in the beginning, when it was a little bit more manageable, we did recommend patients call ahead of time. And then we also have a lot of patients, right now they do have a screening process where you can call some, I don't know where they get the telehealth number. They'll direct them to either telehealth counseling or go straight to the center, go to the ER.
Yeah, interesting. I don't know. Does Japan have telehealth or like virtual? I don't think they have like virtual clinic right now, right? Like, do you know, Dr. Oya, do you guys do like virtual, like online telehealth in Japan? I'm not familiar.
This is kind of new area, and some of the clinic has opened those web how can I say clinic centers and that, but still it's behind. So it will be how can I say going well in the future.
In the future, how is COVID in Japan right now? Like the hospital and
I guess
situation right now.
it's a kind of disastrous situation, especially Tokyo and Yokohama. But fortunately, our area, Shizuoka, a rural area, and the number of patients is not so high. But still, we very how can I say keen, sensitive about the patients with COVID. So in our emergency department, we usually order majority of the patient for PCR. But the other emergency center, the patient, if the patient had a non-respiratory or fever symptoms, the physician would order COVID antigen test first. And if the patient had any fever or respiratory symptoms, they would order PCR. And that would be the ordinary screening test in the emergency department in Japan, I think.
Yeah. Do you guys have a reasonable result time for your tests? Because I know some of the places that I work at, if someone got a PCR test, sometimes it takes like 4 days to come back. Not in Utah, but sometimes in Wyoming, it takes days to come back with the result if it's not the antigen test.
And in terms of PCR, it takes about 1 day. And we now introduced in hospital PCR test. It's just 1 hour or a couple of hours, so it's gonna be good.
That's good.
Also in Japan, are the Japanese physicians wearing like N95 or PAPR? Because like my sister works in a hospital, she's like, no, we don't have any N95. So what is the situation there? I'm just like worried.
It's supposed to be wear, for include N95, but because of the shortage of the PPE, it depends on the facility. But our facility relatively had a amount of PPE, so we wear, full PPE.
Okay, good, relieved.
So I have a question from the audience. Thank you for your lecture. How do you think about health insurance system in the United States? I think especially in emergency medicine, everyone has the right to medical care, but is it just ideal in the US?
Ooh, I think our health insurance is terrible here in the US. Fortunately or unfortunately for me in the ER, we don't look at any, like it doesn't matter if they have health insurance or not. And by law, we have to see them. By law, we have to give them their medical care and at least do a medical screening exam. We are not allowed to say we can't treat you because you don't have the right type of insurance, or you can't pay, or we just don't like it. Whereas a clinic or private practice place can do that, you know. So that makes it a little bit easier, but then also it ends up being a poor use of resources, because a lot of these patients should end up seeing a primary care doctor for a lot of their problems, but coming through an ER is always going to be more expensive. But if that's, unfortunately, it ends up being that the ER ends up dealing with a lot of the problems that our regular healthcare system fails. You know, that's the entry, we call it the entry into the medical world here, because that's where people go most of the time. For me, even as someone who has health insurance, I find it very difficult to navigate as well. So I can't imagine, like I'm a physician and I find it hard to navigate where I should get my care, how to set up an appointment to do this or that, or who is able to see me with my insurance. That I can't imagine that it's going to be that much, it's going to be too easy for patients. So, and it does get hard for people who have chronic problems. Unfortunately, I'll see them a lot in the ER for the same issues. Like, oh, my blood pressure is not under control. What do I do next? And like, if you had a primary care doctor, they can change your medicine for you or add different medicines for you. So it ends up, so a lot of people that do emergency medicine like to see the acute problems, but then they don't like seeing the primary care issues. So that's also contributes to part of the burnout as well. It's just unfortunate that we have it this way here. I think a lot of the cost and preventative care could improve a lot of the health outcomes for people here.
Thank you. And I see a hand up, so let me unmute.
Hi, can you hear me?
Yep.
Okay, thank you so much for your presentation. I'd like to ask you a couple of questions, but I'm afraid my questions will be to me specific and not contributed to other people. So could I ask you those questions after everybody's out?
Yeah, you can, yeah.
Thank you. Thank
my
you so much.
email is in the chat box, so you can just email me too.
Thank you.
Mm-hmm.
Any other questions?
Okay, so it's almost like 2 hours now, and very fast, but it's very interesting subject, and particularly this time of the COVID, and I think many people learn a lot, you know, from you about the U.S. system, difference from Japan and the United States, and I hope not many people kind of discouraged from the situation in the United States emergency room. But I'm sure there's a lot of Japanese young student, resident, very interested in coming to the United States to learn about emergency medicine. So hopefully, your talk was helpful, for them.
Yeah, I mean, there's a lot of bad things in the American healthcare system, but I would never change my job. I love the job that I do. So I think, despite all the difficulties, like you're trying to make a difference, a positive change.
Yeah.
So hopefully that's motivating enough for the students or any of the other doctors.
Yeah, good. Thank you.
Mm-hmm.
Okay, I think I like to finish this, and then hopefully I can see you someday.
Yeah, it might help next time if you gave me there was a topic that you were very, very interested in, so we can make it more specific and less.
More specific.
Yeah, because every topic is like, so you can get into so much detail.
Yeah, but thank you very much for your contribution and willingness to teach. And hopefully I can see you. Maybe you can come to Hawaii. I can see you face to face.
One day.
One day, okay. Anybody else? Okay, so we're gonna finish this. So you need to talk Kawai using this Zoom, or what should we do?
If on the Zoom, that'll be easier for everybody, I guess. And I
can stop recording now, and everybody.
That'll be great. Thank you.
So can I stop the meeting, or what should I do?
Oh, I think you can just leave.
Like as co-host, so everybody else can leave.
Yeah,
and
if you leave, it's still going to be here.
Will automatically be host if everybody else.
I see. So I'm gonna stop the meeting from my side. Okay.
Yeah, you just hit leave.
Okay.
All right. Thank you, Dr.
Thank you very
Machi.
much.
Thank you, Dr. Oya. Thank you, Amy.
Bye.
Bye.
I'll leave you guys.
Okay.
Have you guys gotten the vaccine in Japan yet, or?
I think not yet.
Not yet.
Maybe February, I think.
Oh, I see.
I
need to get my second one.
Oh, nice. It didn't feel that bad. I had my second one and it was just a little sore. So
oh, really? Like some of the people are like, oh, you should get your second one on your day off. And I'm like, I don't have a day off. Like you don't do vaccine on weekends. And I'm like,
yeah, I know. I don't know. One of my friends got angioedema and her face like swelled up the next day. She's like, oh my God.
Really?
Yeah, she ended up fine. Like she just took some prednisone and just watched herself at home. But she was like, oh my gosh.
I would not want to have that on my work day.
Okay. I'm gonna leave now. So have a good day.
Okay.
Be careful and stay safe and healthy. Okay. Okay. Bye.
All right, you too. Bye, guys.
Thank you. Bye.